if I use variable RBE. So inside it is higher, outside it is lower, and that's exactly what I want. And this is just using a very simple model. As we produce better models, I think this effect will improve even further. So as I'm trying to say that the currently used models are rather simple, they're limited, and they're based on insufficient, inconsistent data. And as we learn more, I think we can improve these models. And very quickly, I just want to mention that it's really important that we conduct clinical trials. Clinical trials are important not only to compare photons and protons and to see if protons can truly be better than photons, but also they produce data that we can use to learn and improve proton therapy further. A large number of single-arm phase 1, phase 2 trials have been conducted. Many more are being done. Only one randomized proton versus photon trial that has been done for long, and this is at MD Anderson. We just finished this. We are studying it. And I have to say the results are not as good as we thought they were going to be. I have to admit that. And the data will be presented, and my worry is that people are going to claim, oh, then protons are no good. Well, it will be tragedy if that is what happens. It is that we learned a lot. We now understand now what could be the reasons why the results are not as good as they can be, and we are analyzing it. So it's a great source of information, great source of knowledge, but I hope people will not jump to conclusions about protons based on that. There are many other randomized trials we're doing at MD Anderson, and there's oropharynx, esophagus, glioma, liver, lung, and so on. Trials, randomized and other high-level evidence is really important. It is necessary. But at the moment, we also have to realize that technology-based trials, randomized or not, are not easy to do. Over the course of radiotherapy, and over years it takes to do the trial, 4, 5, 6 years, technology is changing, our experience is changing. So the patients who were treated early on may not benefit from the new advances. Let's say 5 years later, now we have IMPT. When we started, we didn't have IMPT. Should we deprive patient of the new advances? Should we maintain what we were doing 5 years ago? Should we not use our new experience to improve them? So those are the kinds of things that in the beginning, we were not able to show the advantage of protons, but maybe later on we were. But so the changing technology makes it very difficult to do the trial compared to say chemotherapy trial. It's the same drug you're giving regardless of number of patients and when it is done. Experience and expertise changes as well. And there are many other reasons why doing trials is difficult. So finally, to summarize, protons and other particles, I think, have high potential for targeting tumors and reducing exposure to normal tissues. Ongoing research and development will help realize their true potential, and the examples include improved image guidance, improved dose-response knowledge, and improved knowledge of RBE, and the use of IMPT. Passive scattering protons versus IMRT is not the right thing to do. That's what we did with the lung trial. We thought protons were so much better that even with the 3-dimensional protons can beat intensity modulated photon. In fact, we were told that it is unethical to do that trial because protons, we know the protons are better, not the fact that IMRT is better than proton, but so don't do the trial because it will be unethical. You'll be depriving patients of proton. It turned out that was a mistake, not because of what we were told, but because perhaps we should have waited for IMPT. Randomized and other high-quality clinical trials are essential to evaluate and demonstrate the true effectiveness of protons, and to understand the factors affecting response to proton therapy to continue to improve its effectiveness. So one thing I learned, and I thought this was my quote, but it turned out that 2,000 years ago, Plato said this. Socrates said that. More you learn, more you realize how little you know. I mean, there's just infinite amount to learn, and what we know, and this applies to protons also, you need to learn more and you need to utilize the knowledge to make things better. Thank you so much.
Going back to the point, robust optimization.
Mm-hmm.
You were talking that robust optimization has led on probably tumor shrinkage as well as tumor movement, for the uncertainty of tumor movement as well as uncertainty of tumor shrinkage. But
Okay.
optimization in terms of tumor movement can be to a certain extent gauged, but how about tumor shrinkage?
Yeah, very good point.
Because each tumor behaves differently,
As-
each patient will behave differently.
Mm-hmm.
So how do you do that optimization?
Okay. Let me first tell you how we do optimization when we don't have to worry about tumor shrinkage first. Let me first start with that. So what we do is that let's say for CTV to PTV use a margin of 5 millimeters in the clinical practice. Then that assignment of margin is based on some prior experience or studies done some institution or another who believe that if we assign that 5 millimeter margin, tumor will remain within the dose distribution prescribed dose distribution. So then, if that assumption is correct, then we say, well, we're going to generate multiple dose distribution within that by shifting the tumor right, left, up, down, inferiorly, superiorly. And so we have 6 different dose distribution by doing that way. In addition, we have range uncertainties that makes it plus or minus 3%. There is some evidence that that's the range uncertainty. So that's 8. 9th dose distribution will be without shifting anything. So we have 9 different dose distribution patterns. So we optimize in such a way, so regardless of where that thing is, it is always covered. During optimization, we make sure that all these 9 dose distributions are taken into account. The result is a robust treatment plan that is insensitive regardless of where it is. So it's insensitive to range uncertainty, it is insensitive to shifting within that 5 millimeter margin. Now, you say, well, what about the tumor shrinkage? Well, as I mentioned to you, what robust optimization inherently does, it makes the dose distribution gradients shallow. So if there is an IMPT plan that sort of is fitting like a jigsaw puzzle, very sharp ends, it's no longer fitting like a jigsaw puzzle. The gradients have become shallow. So even there, if there is a shrinkage or tumor, that change becomes less sensitive to changes. So it's just a fortunate thing. Although we have not done robust optimization to incorporate tumor shrinkage, luckily, robust optimization results in a plan that is less sensitive to tumor shrinkage. It is not perfect, but it is in the right direction. Does that answer your question too?
Those outside the tumor will be more painful. Suppose the shrinkage is there, do we have there will be more?
Okay. Yeah. Yes. Then what you do is, like I said, then you have adaptive replanning. That's what comes into play. So you cannot. So that's the other point. Even though we may not do robust optimization to incorporate that, it will become less sensitive to changes, but at the same time you need to do adaptive replanning.
Adaptive replanning is probably easier than looking at robust optimization, because in robust optimization, you're just assuming that this tumor is going to shrink and you give variability.
I think
Here in adaptive radiation, when you try, you image the patient, you plan it a day. So you know exactly this is what is it. And the next week you again do a planning again, you do a CT, you draw the volume again.
Yes.
So you know how much shrinkage is taking place.
Yes.
So it definitely gives you a concrete evidence. Here in this situation, it is only a kind of assumption which you are trying to do on the whole.
Yeah, you're correct. I think you need both. You need both robust optimization and you need adaptive replanning.
Do they correlate well?
Pardon me?
Do they correlate well?
Oh, absolutely. There is no reason why you cannot. So every time, because let's say when you do re-optimization that can be robust optimization. There is no reason not to, because you probably will not do adaptive replanning every day and every time the patient is sitting on the lying on the couch and you have to go run, make an image at the time, and you create a new plan. That will be very difficult to do. But if there are shifts in position, if there is range uncertainty, you can take that into account by robust optimization. The point that we're making here is you need to minimize uncertainties as much as you can. You cannot entirely eliminate them, and residual uncertainties will be taken into account by robust optimization. You have to minimize. Yes?
The case you showed on the brain necrosis and hemorrhage.
Yes?
The tumor is particularly in the optic chiasma region.
Okay.
What is the normal tissue impact with this kind of necrosis and hemorrhage you have seen? Because almost the volume covers the optic chiasma.
Yes.
So what are the observations?
Well, the changes in images and necrosis and then cognitive function decline of the patient. I'm not entirely familiar with it, but I think maybe if there are physicians in the audience, they may be able to. Yeah, so maybe they can give you a better idea, but our goal was changes in images occurred, and that were not foreseen, and we were trying to understand why the changes occurred and could that be related to RBE. But the necrosis sometimes resolves by itself, as I understand it, but sometimes it leads to cognitive function decline, and maybe somebody...
that is more a visual, particularly the visual effect.
Yes?
Whether it had an impact clinically or not, whether the patient's vision deteriorated.
Sure.
Make more understanding whether the necrosis was confined within the tumor or also.
Yes.
Because you said the necrosis was more on the edge. The necrosis was
In
more
the-
on the edge.
Yes.
That was the area where the optic chiasma was
Yes.
placed.
Yes.
So I wanted to know the clinical.
I don't remember or I don't know what this was, but generally speaking, there is some cognitive function is affected and some other issues, blindness sometimes, But I think mostly our physicians who are looking at these are telling me that's mostly the effect on cognitive function decline, yeah.
Last year end, you installed one MR reacting challenge. So do you see any role of the MRI scanner inside the proton transducer?
Yeah. There are people thinking about it. There are some papers being published. It'll be really nice to have an MR coupled with the proton therapy system, but I think it's even more complicated than MR-Linac. So there is my colleague, my friend and colleague Paul Keel and one of his collaborators are working in Australia on developing, or not developing, but at least just doing some simulations of this thing. And I think there are some other people in Europe also considering. IBA is secretly supposed to be developing an MR proton machine, but I think it's probably far into the future. So are there any places here in India that are getting MR-Linac? Is any thought being given? Pardon me? Yeah, we have acquired one at MD Anderson. We haven't started using it. We'll find out. Presumably it will have some advantage, yeah. We'll see. You can, I'm not an expert at all. I only know that you can, pardon?
Has it been commercialized?
What?
MR-Linac?
Yeah, Electa sells it. You want to buy one? No, we bought one. It's expensive. I have no idea how much it is, but they didn't tell me. But also, MD Anderson got a good deal from Electa because they want to place their device at MD Anderson, so they gave us a good deal. But still, I don't know how much we paid. Yeah, I'm not involved in that project. Yeah. Pardon me?
Stopping for uncertainty in the planning part. Stopping power.
Stopping power.
Uncertainty.
Yes, that's the range uncertainty. So that's included in that. Yes, sure. Yeah, stopping power uncertainty. Stopping power uncertainty translates into uncertainty in range, and so there is an estimate. We use in the optimization we did. We assumed it to be plus or minus 3% in the range. But I think with newer methods using certain kinds of dual energy CT scanners, for instance, you can reduce that range uncertainty. So again, you want to reduce uncertainty as much as you can, but take into account whatever is residual uncertainty. Yes?
So in the lung trial that you compared protons with photons, the margins that you used was the same?
Yes. The margins for GTV to CTV were identical. CTV to PTV were the same. However, one other thing that you should mention, which I didn't say, protons, because the way they scatter, they have a wider penumbra. So you have to, between the 50% boundary and the PTV, the distance is a little bit larger than you'll see for an IMRT or VMAT case.
Imaging was done every week?
Pardon?
Imaging was done every week?
In the clinical trial, we did imaging every week. So over a 7-course treatment, there were 7 or 8 CT scans made. And so this is an opportunity to learn. So what we're going to do is, so we have 7 different CT scans, even though tumor is changing and motion is, these are 7 4D CT scans. So we're going to use them to calculate 70 different dose distributions, because there are 10 phases of each 4D CT. For each patient, 10 times 7, using Monte Carlo calculation, and then we're going to use deformable registration to add them to determine the dose we consider to be actually delivered. There'll be a better approximation of dose that was delivered compared to dose we thought was delivered based on the original treatment plan. And then we'll try to correlate that with toxicities and failures or changes in images to try to understand. So it's a lot of work, but it may be necessary in order to understand what actually happened. One of the things we may find is that the volume of tissue irradiated with protons is larger. You know, the question about margin, like I said, the penumbra is wider. That means the volume inside the 50% isodose surface may be larger for proton than for photon. Could that be a factor? We don't know.
So that's why I'm a little surprised when you say that because you feel that the results are not superior, right?
I think that's what will be shown, that we cannot tell whether protons are better or not.
So then why do you say that IMPT will probably make a difference? If the 4D CTs are done, you have an adequate margin, in what way IMPT is going to improve your outcome?
We have more control. We have more control over dose distributions. One of the things is that in passive scattering, one of the things we do is we create compensators in the path of proton so that the distal edge conforms to the target volume. So we shape it in such a way. And then what that does is, while it reduces the dose from beyond the distal edge, it pulls the dose forward proximal to the target volume. So you have not taken away the dose, you just have pulled it towards the surface of the patient. Whereas with IMPT, you can not only reduce the dose beyond the distal edge, you can also control the dose in the proximal edge. So there will be less dose deposited with IMPT in normal tissues than with passive scattering. That's one reason I can think of. It's a really good question. The other is that if we use biological effectiveness as a part of it, we can then find a way, using special techniques, that higher RBE protons preferentially deposit those in the tumor, because protons have different RBE. As you know, the ones that are in near the distal edge have a higher RBE than the one toward the surface. So we can manipulate IMPT to put more of those high RB protons to be in the target volume. So that is one of the other factors that I think can be. So there are some of those kinds of factors that I think we cannot control that in passive scattering, but we can do that in IMPT. And there may be other reasons. Yeah. By the way, even without that, we found that IMPT plans were superior compared to IMRT plans. Passive scattering plans were not always superior compared to IMRT plans. I have at least one example here which I didn't add to this, but I can. But we were going to do a trial for IMRT versus IMPT, and they're still being considered, for lung, Yes?
What's your comment on integral dose between photons and protons?
Yes, integral dose is almost always lower with protons, almost always. But even then, what interesting thing is that integral dose may not be all there is to it. Integral dose definitely is something to be, it's a value, reducing in integral dose. But there are many other issues. So, you cannot just assume that because the integral dose is lower with protons, the outcomes will be better. And this is my point, that those patterns are so different with protons and photons. We need to learn about the effect of integral dose. Did I answer your question? Okay. Okay, anything else? So we can, by the way, continue. We can grab some dinner and come back. And
Good evening, everyone. It's on a working day. I think so many people have walked in and spent an hour with an expert, Dr. Radhe Mohan, in this evening. Thank you, sir, for accepting our invitation and giving us from basics to the latest available in proton technology. And we have given a 3 days short notice for you to all assemble, and you all taken your time to come and attend the meeting. I think we are taking a message of how it is going to be in the future. In the morning, in the informal talk, he was mentioning that the passion we have to have for the work, actually, especially physicists, especially the proton center, which is going to